Topics in dermatologic surgery, common benign and malignant skin disorders, written and narrated by Dr.Boyd. Hiddradentis suppurativa is a chronic inflammatory skin condition of follicular occlusion with lesions including deep-seated nodules and abscesses, draining sinus tracts or fistulae, and fibrotic scars. These lesions most commonly occur in intertriginous areas. Most commonly affected areas are the axilla, groin, perianal, perineal, and inframammary regions. Surgical management can be pursued at any stage to remove areas of active disease and limit complications, but it must be combined with appropriate medical therapy. Marginal ulcer. A marginal ulcer, historically referred to as a squamous cell carcinoma within a burn scar, but the definition evolved to incorporate all skin malignancies arising within damaged tissue. Squamous cell carcinoma remains the most common malignancy. Marginal ulcers can occur many years or even decades following the initial injury. Diagnosis relies on clinical suspicion and is confirmed through biopsy, with imaging used to assess local invasion and distant spread. The most common treatment for non-metastatic disease is wide local excision with at least a 3-centimeter margin. Persons with well-differentiated marginal ulcers have a 3-year survival rate of 65% and a 5-year survival rate of 43%. Those with metastases at the time of diagnosis have only a 3-year survival rate of 35%. Despite its name, Pyoderma gangrenosum is not caused by infection or gangrene, but falls into the category of neutrophilic dermatoses. It's characterized by rapid progression of painful, necrolytic cutaneous ulcer with an irregular, violaceous, and undetermined border. Pyoderma gangrenosum is often associated with systemic disease, most commonly rheumatoid arthritis, inflammatory bowel disease, Crohn's disease, and other autoimmune and inflammatory conditions. Condyloma acuminata refers to anogenital warts caused by human papillovirus, HPV, commonly spread by sexual contact. Condyloma acuminata are usually asymptomatic, although they may occasionally cause bleeding, pruritus, and pain. Available treatment options are many and include topical therapies like podophyllin and trichloroacetic acid, cryotherapy, and surgical incision. Actinic keratoses are lesions that commonly appear on sun-exposed areas of the skin in individuals with a history of cumulative sun exposure. Actinic keratoses typically present as rough, scaly patches on the skin surface resembling sandpaper. These patches often appear pink, red, brown, or even flesh-colored. They can vary in size from a few millimeters to several centimeters. It's considered a precancerous condition because if left untreated, it progresses to squamous cell carcinoma. Diagnosis is by clinical exam, dermoscopy, and/or biopsy, and treatment includes cryotherapy and topical 5-FU cream. Basal cell carcinoma is the most common cutaneous malignancy, affecting close to 1 in 5 Americans. Basal cell carcinoma mostly arises on sun-damaged skin and appears as flesh or pink-colored pearly papules, that's with pearled edges, and a waxy central depression. Basal cell carcinoma occurs on the upper part of the face in the majority of the cases. Biopsy should be performed in all patients with suspected basal cell carcinoma to confirm the diagnosis. Complete surgical removal is indicated. Squamous cell cancer is the second most common skin malignancy in the United States. It's characterized by a scaly, erythematous, hyperpigmented papule or flat plaque. A skin biopsy is necessary to confirm the diagnosis of cutaneous squamous cell carcinoma. Additionally, sentinel lymph node biopsy and/or radiological evaluation for lymph node status with computed tomography or ultrasound is recommended in the more advanced cases. Merkel cell cancer. Merkel cell cancer typically presents in the elderly patient as a rapidly growing, asymptomatic, firm, red nodule on sun-exposed skin, with head and neck region being the most commonly involved. Merkel cell cancer is a rare, aggressive skin cancer that often has local or distant metastatic spread at the time of diagnosis. The prognosis is poor. Definitive diagnosis is made with a skin biopsy. In addition to a biopsy, a lymph node evaluation should be performed in all patients. Treatment of Merkel cell carcinoma consists of wide local excision of the primary tumor with a 1 to 2 centimeter margin, possible lymphadenectomy, and postoperative radiotherapy. Malignant melanoma. Malignant melanoma is the most lethal form of cutaneous neoplasm and accounts for approximately 15% of cutaneous cancers. Melanoma has a relatively high risk of systemic spread. The mnemonic to recognize melanoma is A, B, C, D, E. Asymmetrical, A, with irregular borders, B. There's variation in coloration, C, and a diameter exceeding 0.5 centimeters, D, and they have evolved, E. The prognosis and management of melanoma is determined by its depth of invasion. For lesions with a Breslow depth of less than 1 millimeter, the treatment is local excision. Deeper lesions required wider excision and lymph node evaluation or lymphadenectomy. Metastatic melanoma occurs in unusual sites, and the outcome is unpredictable. The patient may be dead in a few months or may live for many years. Treatments include chemotherapy and immunotherapy. Lentigno maligna, or Hutchinson's freckle, is a slow-growing subtype of melanoma that often occurs in elderly on the chronically sun-damaged skin, particularly the head and neck. Lentigno maligna is the third most common subtype of melanoma, comprising 4 to 15% of all melanomas. Mean age of diagnosis is 66 to 72 years of age. Lentigno maligna was thought to be either benign, infectious, or precancerous due to its slow growth. Today, lentigno maligna is defined as a melanoma in situ on chronically sun-damaged skin. Therefore, lentigno maligna is confined to the epidermis. Surgical excision is the treatment of choice. The 5-year survival rate is 100%. Acromelanoma is a melanoma occurring on the hands and feet. It accounts for about 3% of all melanomas and occurs more often in non-white patients. Average age of diagnosis is 63. Wide local excision is the primary treatment for acromelanoma. If metastases are detected clinically by palpation of the local lymph node bed or by sentinel node biopsy, systemic treatment with chemotherapeutic agents is used. Acromelanoma is often presented in a more advanced stage with positive sentinel lymph nodes and the strongest predictor of disease recurrence and death. Subungual melanoma is a distinct subtype of cutaneous malignant melanoma arising from the structures within the nail apparatus. Most patients present as a dark black vertical band involving a single nail. A nail bed biopsy should be performed using digital nerve block. The nail plate should be carefully removed and a full thickness biopsy should be taken of the pigmented area. For many years, the only acceptable option for management was digital amputation. In situ excision surgery for lower grade melanomas is a reasonable option. Sentinel node biopsy should be offered to all patients with melanoma of a depth of 1 to 4 millimeters.